A warm good morning to everybody. Now, from glaucoma, we move on to uh, the next session on cataract surgery. How to give best results for cataract surgery. At the outset, let me thank Dr. Bastin, the scientific committee, and Ksos for the opportunity. So we have a lot of stalwarts in the field talking to us. So let me call upon Dr. Chitra Ramurthy, who will be giving the keynote address on ASOCT guided management of posterior polar cataracts. Dr. Chitra doesn't need any introduction. She's the medical director of the Eye Foundation Group of Hospitals and a prolific phaco-refractive surgeon and a great leader of AAOS and TNOA. Over to you, Dr. Chitra Ramurthy.
Very good morning to one and all of you, and thanks so much, Dr. Soni, for a very kind introduction. So, without wasting time, I'm going to take you on to how anterior segment OCT based management of a posterior polar cataract gives us a greater ease in identifying which are actually routine cases. Now, all of us are familiar that in a polar cataract, we make a smaller excess because there's a possibility we have to place the lens on the excess. We will not do hydrodissection. We will do a mechanical delamination, hydrodelineation. We will not rotate the nucleus. See how eating up the epinucleus and the cortex, getting the endonucleus out, at all time keeping my IOP at 30 millimeter, no anterior chamber fluctuation, and then eat up the entire thing, no posterior capsular polishing. And you never know, at any point of time you may be having a PCR. So it becomes a challenging case. The fact that you have not rotated nucleus, not done a hydrodissection, it can become time consuming. Now, ASOCT shows all these cases as posterior polar cataract. Which are the innocuous one? Which are the ones which are having a posterior capsule open? Is something repeatedly we have come to understand in the recent years that ASOCT, the swept source one, definitely helps you understand whether there's a continuity in the posterior capsule. You could use the intra-op OCT, the OCT guided phacoemulsification, which will take you through the different steps, all the time visualizing whether the posterior capsule is intact. Even femtosecond laser assisted cataract surgery is done. It has the swept source anterior segment OCT, which tells you whether there's a posterior capsule adhesion. If not, you don't have to keep a higher offset. So there are any number of papers which have come forward. To understand now the group 1, it has you are able to continuously see that inferior continuous line which shows that the PC is intact. In the group 2, there is that hazy smudge, and you're not able to trace the posterior capsule under that opacity. So it's discontinuous, which means the PC is open or likely to be open. And in group 3, that PC is actually dehiscent with the contents are already in the patellar fossa. So in group 1, where it is a PPC with a continuous posterior capsule, now I'm going to tell you what differently you can do. What you can do is you make your nice round rexes. You are cognizant that this is a weak posterior capsule, but you can do a hydrodissection. You have seen PC continuity. There is no harm in doing a hydrodissection. Keep your IOP low, keep your parameters low, but you can rotate the nucleus. Everything in a gentle manner. Do your chops, remove your cortex, and you could even dare to polish the capsule if you want. See the posterior capsule intact, carefully inject the IOL, but then it's a safe procedure. If you were to do on a femtosecond laser platform, there are certain things, the manipulation in the anterior chamber is so reduced, the capsular excess is free floating, and all those fragments are already created. You can gently rotate, and you can just carousel it out, eat it up, keep your IOP low. I agree that it's a posterior capsule to be watched, but in that group 1, wherein you are seeing an intact posterior capsule on ASOCT, are definite cases where you can do a routine cataract surgery and not make the surgery a challenge. And sometimes the complication is not because of the posterior polar cataract. Here I have even dared to do a posterior capsular polishing, which normally we may not. We need not dare to do that if necessary, but you can get away. Now these are the Group 2, where the posterior capsule you can't trace. Look at the ASOCT. You're not able to trace it. So then, how would I do my surgery? Now, herein again, I would make a small recess. Because here, I will not do a hydrodissection. I would only do a hydrodelineation. I see that golden ring. And I'm not going to rotate the nucleus. I'm going to debulk the superficial epinucleus. Then I make a small trench because it's a moderately hard cataract. And then this gives me a better approach to do my direct chop. Now let's remember, I'm not rotating, but with a visible area at the 6 o'clock, I make 2-3 pieces, loosen them up. And once I eat one piece, I have created more space in the posterior capsule. The intracapsular pressure is reduced. So I can even do a viscodissection now. And then I would rotate the nucleus and chop it into further smaller pieces. So, but all the time when I remove my instrument, I would inject viscoelastic. I would not want to have any change in the hydrostatic pressure in the posterior capsule. I will keep my phacoprobe in the center and complete the case. Now here, the PC is dehiscent and the contents are in the patellar fossa. So that means the PC is open. So you are sure shot operating on an eye where the posterior capsule is already open. You know there could be a nucleus drop. So this is a very careful surgery. Hydrodissection, no rotation, hydrodelineation, no rotation. I've completed the surgery. But see, the vitreous is not there. Although there seem to be some the disturbance in the anterior vitreous. And I've managed to place the premium IOL in the capsular bag and got away. We did an analysis of 71 eyes of 49 patients operated by 5 surgeons in the period of 7 months. There were 54 eyes in group 1, 16 eyes in the group 2, and 1 in the group 3. Now, in the group 1, there should not be any PCR, but in this one particular surgeon was a little careless about the steps of the surgery, which only induced that PCR and not because it was a polar cataract. In the second case, out of 16, there were 4 eyes. So although the OCT said, ASOCT said that there's going to be a rent, but it was so only in 4 eyes. So 25% only predictive value was there. And as far as the IOL placement, out of the 54 eyes in group 1, in only 1 it was placed in the sulcus with optic capture. In group 2, there were 13 of them could be placed in the bag, and only in 3 of them an optic capture and reverse optic capture was done. And the most interesting thing is we had promised premium IOLs in whichever patients, all of those patients, in spite of the being a polar cataract, we did not have to change the IOL and we could place the IOL. So what did we understand? ASOCT is helpful in predicting with an intact PC. In 98% of the case, it is sensitive, which is very important. So you will not go wrong if you do a hydrodissection there. Specificity. Out of 16 cases, 4 cases only had PCR, whereas all should have had PCR. So the specificity is only 25%. In other words, the high negative predictive value is 98%, and if it is intact PC, it is not likely to have a PCR. Then, what is the reason for those eyes where the opacity was there and discontinuity was seen? And in group 2, probably the PC plaque is so thin that the ASOCT beam could not pass through. Probably there are only tiny defects which were there, but it was still a continuous PC. Probably it was a very thin PC, but actually it was intact. That's why you didn't have a PCR. So I would like to conclude stating that ASOCT should be routinely performed in all cases of PPC. If PC is found intact, do a routine phaco. Care should be exercised. However, the PC, though intact, can be thin, and all deficient PC do not end up with a PCR. So thank you very much. And since I'll be leaving today by afternoon, in case I have not met some of you in this audience, I'm contesting for the post of Vice President of AIOS. I have been a chairperson ARC only because of you all who voted for me in the earlier election. So please do remember me. I'll give my best to you all. Thank you very much.
Thank you, Dr. Chitra, for that, as usual, wonderful presentation. I only hope more of us can afford OCTs while doing.
No, even the IOL Master OCT will give us an idea. And I think maybe it's the next thing. It will help us a lot. It's not that if you presume even the grade 1, we treat it as a PPC and don't do a hydrodissection, it's okay. It's all right. It's just that the surgery can go faster because you're overcautious in a case where we need not be.
Thank you. And all the best for your elections, ma'am. Now we move on to Dr. Rohit Georgie Matthew. In this era of refractive surgery, we will face many people who have undergone refractive surgeries, and also now cataract surgery is become a refractive surgery. So the importance of precise biometry cannot be overemphasized. Dr. Rohit is a established phaco-refractive surgeon working at the Lotus Eye Hospital, Cochin. Over to you, Dr. George.
Good morning, all. I would like to thank Dr. Soni for including me in this IC. So in this era of refractive surgery, the number of refractive surgeries performed worldwide is increasing. So as the post-refractive cataract volume also is slightly coming up due to age. So the refractive surprises are well known, and the refractive dissatisfied patients are also increasing. So what is the key? It's the accurate biometry. So it's just a basic. After corneal refractive surgery, the main is the relations between the anterior and posterior corneal curvature. That is the Gulstrand's ratio. The normal is around 0.9 to 0.93. Whereas in myopes, if you see, the center area is flattened and the periphery is thicker. Whereas in hyperopes, the center is thicker and the periphery is flattened. So this ratio is being altered after the refractive surgery. So what does the conventional catometer do? So the conventional catometer, it measures only the 3 mm zone. So that is fixed, and the anterior and posterior corneal curvature is already fixed in the machine. So and it doesn't calculate the central corneal images also. Whereas when you do a post-refractive surgery IOL power calculation, the prefixed value is being used. So that is the reason why you get surprises after the surgery. So the era of estimation of ELP in the third generation formulas like Hoffa-Q, Holiday 1 and the SRKT is that it based on the catometer reading as well as the axial length, resulting in an proper AC depth leading to effective lens position. Whereas in post-refractive surgery, the catometer is varied, resulting in an inaccurate AC depth, resulting in an inaccurate effective lens position. So what is the solution? So there are two ways to approach. One is measuring or estimating the true corneal power, that is objectively a total catometer, and applying correction factor for catometer, like the Pentacam EKR values. This total catometry can be done in the newer generation machines like the IOL Master 700. The other method is using the formula not solely relying on catometer and axial length. Or you can add in the corrective factors of accurate estimation of the effective lens position, like the formulas like the Holiday 2 and the Barrett True K, Universal 2. So if you don't have the latest machines, the older way of approaching is look onto the previous refractive data, which is not available throughout, because if the patient is doing in a refractive surgery in a hospital and the cataract surgery in a different hospital, it will be a different difficult sign area. The other method is use an online calculator to get the basic K values and compare the various methods, and the history and the no history method in the SHAMAS 2, you can do the online calculation. It gives a almost precise value. Whereas in the modern practice, you can try for the topography as well as the optical biometry. So in topography, there are two ways, like the placidosis. It is basically to evaluate the astigmatism level, the ablation pattern, whether it's central or peripheral, and the other one is the Schimflex OCT, to know the equivalent refraction and the true net power. And like optical biometry, the optical OCT based IOL master calculation, both anterior and posterior corneal curvature is done. So this is inbuilt with the formulas like the Barrett True K post refractive surgery and the Barrett TK Universal 2. So this gives a precise value. So another method is total catometry. This is a novel method combining both telecentric catometer and the swept source OCT. The measures the posterior corneal curvature, and it's incorporated in the latest machine like the IOL Master 700. And these our newer formulas are also incorporated in this. So what is happening in a total keratometer? You can see the anterior and posterior side effects of the cornea. The anterior is calculated with 3-point telecentric keratometer, and the posterior one is calculated with the Ksos OCT. It forms a 3D image behind the cornea, and the formulas can be incorporated into the machine to get the proper value. So same as the IOL means the power calculation, IOL selection is also an important one. So post myopic LASIK correction, always choose for a spherical IOLs where the positive spherical aberrations are always there. And for hyperopic LASIKs, go for a neutral aberrations or a spherical IOL. So these are commonly available IOL calculating sites. ACRS does a good job. And in conclusion, understanding the need of patients and counseling is critical in avoiding dissatisfaction in patients with prior refractive surgery. And IOL selection is an important criteria in our calculation. And the aspherical IOL for myopes and aberration neutral for hyperopes. And Placido Topo for checking the ablation and for planning a toric IOL. And never give over expectation to the patient of getting a glass-free life after refractive surgery, because minor changes can happen, and preferably better not to go for a diffractive lenses. The newer generation EDOF lenses are far better, and the monofocal lenses are extended monofocal lenses also do a better job. Thank you.
Thank you, Dr. Rohit, for that wonderful overview. It's nothing like having a person who does phaco and refractive to outline how to go about it. Now, next we go on to Dr. Sandhya, who will be talking about incisions and capsulorhexis. As we know, the importance of the incision, the astigmatism induction, and also the perfect capsulorhexis, which will keep the ELP, effective lens position, is very important. Dr. Sandhya doesn't need any introduction. She's a senior consultant, Cataract and Uvea in Giridhara Institute. Over to you, Dr. Sandhya.
Thank you, Dr. Soni. Perfecting incisions and capsulorhexis for optimal vision. We all know how to do a normal rhexis, so I'm not going into the detail. And an intact rhexis is essential for a good corticocleavage hydrodissection, safe removal of the cortex, and also for in-the-back placement of the intraocular lens. An intact capsulorhexis offers various surgical advantages. In case of an unexpected large posterior capsule dehiscence, the capsulorhexis can be used as a contingency platform on which the IOL can be placed, preventing it from dropping into the vitreous. Now, the overall diameter, most of the foldable IOLs are short for sulcus placement, hence sometimes they may not be very stable. So in case of a PCR, the haptics of a 3-piece lens can be placed over the rhexis, and the optic can be taken under the rhexis and captured, and this will give long-term centration for the intraocular lens. For this, the rhexis size should be around 4.5 to 5 millimeter so that the optic can be captured. Now, proper sizing of the rhexis is also important. So most of the IOLs have an optic of 6 millimeter. So we should aim for a rhexis of around 4.5 to 5 millimeter so that this uniformly overlaps the IOL optic all around, giving axial stability to the intraocular lens and avoid post-op refractive surprises. This is all the more important in case of presbyopia correcting IOLs. Most of the modern lenses have got a square edge. So the circumferential overlap of the optic by the rhexis will produce a shrink wrap effect, wherein the posterior capsule is kinked by the edge of the lens, and that prevents migration of lens epithelial cells from the equator to the center, preventing posterior capsule opacification. Now, a small rhexis is more prone to damage by instruments during phacoemulsification. Here I was trying to remove the small epinuclear plate, and that injured the rhexis. Also, small rhexis are more prone for capsular phimosis, and capsular phimosis is more prone in patients with pseudoexfoliation and soniole weakness. Here, this patient had generalized soniole weakness, and phaco was done with the help of capsule tension ring and capsular hooks. And at the end, multiple nicks were made on the anterior rhexis margin after the implantation of intraocular lens, so that the centripetal forces acting at the capsulorhexis margin is less, and that will reduce capsular phimosis in future. In this patient, when the intraocular lens was implanted, the haptic was crowded and there was eccentricity of the rhexis. though the rexus was secondarily enlarged to make the forces acting on the rexus margin symmetric so that the late decentration of the intraocular lens can be avoided. Here, an apparently looking round rexus became oval after the implantation of a three-piece lens, and this is because of the weakness of zonules 90° away from the area of the haptic. And this rexus has to be secondary enlarged to prevent late decentration and dislocation. So because of the individual variability in corneal magnification and pupil size, manual rexus may not be always well centered and of the reproducible size. So a femtolaser can be used to produce a well centered rexus of a precise diameter. Now coming to special situation, this patient had a mature intumescent cataract. So capsular rexus in mature cataract is challenging because of two reasons. Once there is no red reflex, and so the visibility of anterior capsule is poor. So here trypan blue was used to stain the capsule, and the air bubble ensures uniform staining of the capsule and prevents staining of the endothelium. In the second place, the capsular back pressure is very high and the anterior capsule is convex. In this case, there is a risk of extension of the rexus to the periphery. So you should inflate the anterior chamber nicely with OVD to keep the anterior capsule flap, and a primary small rexus was done, and then the cortex was aspirated to reduce the back pressure. Once the cortex is aspirated, the back pressure comes down, and you can again refill the anterior chamber with OVD, and a tangential nick was made on the rexus margin, and now you can safely extend the rexus to the desired size because the back pressure is not there. Now in this patient, the lens intumescent flecky cortex, we could not aspirate it. So as you can see, there was still intumescence in the periphery and the rexus went out to the periphery and I could not retrieve it. So again, after injecting OVD, the nick was made on the opposite end of the rexus and the rexus was completed. Since there was compromise in the rexus, violent hydrodissection was not done and the cortex at the area of the rexus extension was removed last. Now in this patient with intumescent cataract, in this area, the rexus was trying to go to the periphery. So OVD was injected to make the flap flat, and then using a microrexus forceps for better control, this was pulled centripetally for a better control and the rexus was completed. This is the Brian Little rescue maneuver. And in this patient with mature cataract, when both the instruments were taken out, there was a sudden shallowing of anterior chamber and the Argentine flag sign was produced. So the cortex in the center was aspirated and then OVD was injected and two nicks were made on the either side of the rexus and the rexus was completed. And the phacoemulsification was done using low parameters. If you see here, the flap is motile and then it is everted. So this means the rexus extension has not gone onto the posterior capsule and so you can safely place an intraocular lens inside the bag. Now coming to incisions, the phaco incision should be secure, self-sealing, astigmatically neutral and of appropriate size. So there is increased risk of iris prolapse and wound leak with short tunnel, and in long tunnel there is difficulty in manipulating the instruments and their visibility will be poor and there is increased risk of Descemet's membrane detachment. So in this patient, while introducing the phaco probe, more force was used. And then there was a small Descemet's detachment at the wound area, which was, there was a small Descemet's membrane detachment in the wound area that was overlooked because the pupil was coming down. And then this phaco was completed by, if there is a Descemet's detachment which is large, then you should take a new site for creating a clear corneal incision and phaco can be completed safely through that. Stuck full slide. Next slide. Sorry for that. So here there was a large Descemet's membrane detachment was there. Oh, it's again getting stuck. So I'll go to the next video. So in this patient, when the irrigation was started, there was accumulation of fluid under the conjunctiva, and then there was 360-degree perilimbal chemosis with pooling of fluid on top of cornea, which was impairing visualization. So here, because of the excessive phacoenergy and inadequate irrigation aspiration, there was wound burn. This is evidenced by the whitening of the wound margins. So all these, in these conditions, you can place a suture. And to summarize, a perfect capsulorhexis and incision are extremely important for safe phacoemulsification. Thank you.
Thank you.
Sorry for the delay.
Thank you, Dr. Sandhya. With those videos were great, and you have touched upon the nuances of incisions and importance of a good capsulorhexis. Now, moving on to Dr. Matthew Kurian. He'll be talking about perfecting nucleotomy for clearer corneas and optimal IOL placement. As we know, it's very important in the era of refractive cataract surgery, how important it is to avoid residual errors. And nucleotomy is very important in that. And Dr. Matthew Kurian is a very senior and accomplished cataract surgeon. And he is the medical superintendent of Chaitanya Eye Hospital, Palariyottam. Over to you, Dr. Matthew.
Thank you, Sony. It's an honor to be part of your IC once more. Can I start from the beginning, please? I have financial interests in electronic medical record company and in a portable OCT company. So creating segments is the primary safe step of cataract surgery today. So technique-wise, divide and conquer, stop and chop, or primary chop. And the skills that we require is trenching, cracking, or chopping techniques. Challenges would be cheese wiring, leathery posterior plate, or inadequate grip. Removing the segments, irrespective of the technique, is always the same. What we do, the three techniques that I have mentioned now, are very old techniques. 1990, it was described, divide and conquer was described, but using a different name, in situ fracture. What we call divide and conquer today, the name was given by Gimbel in again 91, but that is actually a version of stop and chop. Conventional trenching is to create these long trenches, cruciate incision trenches, but the problem is in the distal portion. As long as you are up to the midline, there is no problem because you are parallel to the posterior plate, posterior capsule. Crossing the midline hits the posterior capsule, and that is where the challenge is, because you have to make the phacoprobe follow the curve, go up, and the hardest nucleus is in the center, and as you cross the center, your foot pedal has to ease up. When you don't do that, you go through, hit the posterior plate, you can see the change in reflex, and you can see the fluttering of the lens matter. The rent has already happened over here. Okay, so what I call this is a three trenches technique that I use, and it's based on Gimbel's downslope sculpting, which was published in 92. So proximal downslope sculpting starts from just within the rhexis. As you make your superficial groove, you can see cross striations, little deeper groove, intermediate trench, cross and linear striations, and further deeper groove, you will see all linear striations as you come to the posterior plate, and that's called a deep trench. So superficial trench, cross striations are visible in the floor in the red glow. Little deeper groove, cross and linear striations are now visible. And if you want to do, this is the intermediate trench, and if you want to do divide and conquer, which is what the starting technique is, you need to go further deeper than that. But what I suggest is, instead of crossing the midline, you do it in two halves. Do your proximal subincisional up to the Purkinje images in the middle, rotate the nucleus 180 degree, complete the groove to your appropriate depth. Once you have this, then a 90-degree rotation and go deeper, 180-degree rotation again, and complete the cruciate trenches. And use good magnification, use good fine focus for the depth of the floor. And then you will be able to see the Y suture on the floor of the trench. And this is a biological imperative that all lamellar nuclei have got this Y suture at the posterior plate. And this is published in 2013 as the Y sign, the clinical indicator to stop trenching and start cracking. So once you have reached this, there is not enough thickness at the posterior plate to hold and do a chopping. You only have to do a divide and conquer. When you do a divide, you make sure that the division is complete. You can see here that there are few fibers which are going across. Complete. The apex should be completely separated. Free floating quadrants or nucleus segments are so easy to remove. Come to the center. Under the Purkinje reflexes, that is the safe zone. Stay there in the rexus plane, emulsify 3-2-3-2 on the foot pedal. Use your second instrument to reposition. Fluidics will also help to reposition the nucleus, and the entire procedure becomes so safe, so smooth, and you'll be thinking, what's the fuss about? Okay, so that is divide and conquer. You don't need to go that deep to do chopping techniques. Intermediate trench, again published in 2018 JCRS, lens fiber orientation during phaco chop. And the reviewer said, perhaps surprising that this has not been published earlier. Because all of us, when we are operating, I'm sure everybody in this audience has done at least some phaco, and you should be seeing this. If you had bothered to improve the fine focus, it's there under the nose, it's obvious. It's like the apple falling down. It was up to Newton to talk about the gravity issue. So here, linear and cross striations, optimal to impale at that depth. And here you can see the lamellar fibers. Your phaco tip is impaled right in the middle of that. And that's what allows the split to go to the posterior plate, open it up. And then the segment removal is easy. So what's the superficial trench for? Brunous and cataracts, where the nucleus is very thick, 4.5 millimeters, you may not be able to achieve a full thickness chop at one shot. Vaswada has said multilamellar chop, but the petaloid chop is where you get impaled in the superficial portion of the core endonucleus, not in the epinucleus. And then the core endonucleus is sitting like a knuckle in the middle, and the rest of the thing opens up as petals. Open all the petals up, expose the core endonucleus in the center. You can take out this, emulsify this hardest core endonucleus within the safe confines of those petals of nucleus. Chamber collapse will not happen because it's not epinucleus or cortex which is supporting the posterior capsule and keeping it away from harm. It's the nucleus itself. Now, the posterior plate of the nucleus has not been split. So what you need to do is rotate 360 degree, revisit all the individual petals, separate the apical attachments of those fragments, and then take out those fragments one by one. And again, this allows you to do very hard brown or black brunous and cataract with a leathery posterior plate in a very safe manner, deep within the anterior chamber, away from endonucleus, and preventing the corneal edema, also preventing posterior capsule rupture in this scene. So in conclusion, I would say, when you see cross striations only in the floor of the trench, that is a superficial trench, useful for brown cataracts where you would do a petaloid chop. If you see a little more deeper trench, you will be seeing both cross striations, which is in the proximal subincisional area, and little more towards the center, you will see linear fibers. This is an intermediate trench, useful for primary chop. Doesn't matter whether it is a vertical chop or a horizontal chop. If it's full linear striations, it's a deep trench. Do only divide and conquer over there. And I would urge all of you to go back next phaco. increase the magnification, increase the brightness, adjust the fine focus, appreciate this, and today's world, share and like this if you like. Thank you.
Thank you very much for that masterly masterclass on nucleotomies.
Thank you.
It was really fantastic to see the videos. Thank you very much. Now we move on to Dr. Minu Mathan. He'll be talking to us about perfecting pupil management. It's again very important to get premium results because you cannot be blind while doing a procedure and give good results. And Dr. Minu Mathan obviously is an international hero. He doesn't need an introduction. He's a prolific phaco surgeon and works at Chaitanya Institute, Trivandrum. Over to you, Doctor.
Good morning, everybody. Thank you, Sony, for this opportunity. So, pupil perfecting, making them big and small. You know, we don't need them small, and we don't need them too big also. So, this is the one go-to device which I am using now. It's called the B-Hex. So, they come in 3 sizes. We'll see all those. So, in mid-dilated pupils, I don't do small pupil now at all. A pupil has to be big for me. So, my threshold for using this is very low. So this is a little bit of visco underneath the pupil, and then using forceps. Here you see I am using capsule rexus forceps for this. It is not the ideal thing to use. The rexus forceps comes, the forceps B-Hex comes with that. Please buy that because the curvature and all is more appropriate for that. For the last flange, when I am using the right hand, you can see that there is a Kuglen's hook there. I am retracting the iris and then placing it. It looks very small, the pupil, but this is enough. This is close to 5 millimeters. 5 millimeters is more than enough, but the pupil should not come down below 5 years. That is the point, 5 millimeters. So then you can confidently do any phaco underneath this, and this can be moved towards the side also, so that you can see cortex if it is there in the periphery. And once you finish IOL implantation, only thing is trailing haptic. Don't let it open very widely in the anterior chamber. Even if it opens, push it away from the pupillar area and then place it into the bag. If you drag it along, sometimes the device also gets dragged along. And after that, you can use, we need not disengage all the flanges. It just was subincisional one and alone is enough. I'm just showing that everything can be disengaged like this. And elastic pupils, they remain very round, after using this. Rigid ones definitely will have some sphincter tears. So this is another one. See the harder cataract. So the visco underneath this one and underfilling the anterior chamber is very important. This is the 2.0, which is bigger. So you'll get a 5.5 to close to 5.75 opening. And this is the forceps which comes with the B-Hex. So the first one, you can use paracentesis or the main incision. I put some sodium hyaluronate also inside so that it doesn't shallow. So this is one important point. So retracting and pulling. So you can partially pull and partially retract the iris so that a very gross movement is not required. So here you have a wider pupil and this is a very hard cataract. So even if it is 5 millimeters or 4.5, they are bound to come down during your procedure. That's what I have seen. So you have to retain. This is what I was telling. Don't let the haptic touch the device. Inject it directly into the bag or dial it carefully so that it doesn't. So this one, like I showed you now, it can be disengaged. One can be disengaged and easily pulled out. So this is another case. See, you can notice that this is the third version. This is the B Octa, which is 8 millimeters, which has 8 sides. And so this creates a bigger opening. You can use this for SICS and phaco. For SICS, there was no ring like this before. So I use it, this doesn't come off while prolapsing a nucleus. So we have to get this in first. And these round circles which are there help you to hold the flange. And these 2 finger-like projections, they easily go underneath and use 2 paracentesis and then go from either side. And holding it vertically or at 180 degree opposite angle is very useful. You can easily place it. And after that, using a paracentesis, see sometimes when large arcus is there, it may disappear into the periphery and you may not see. So you can use 2 hands, just retract a little bit and bring it into the area where you can see and then hold on to that. And then again the last one, holding, pulling and pushing. So this way you can easily engage it and it becomes so widely dilated and nothing happens. IFIS also very, very useful it is. So I don't want to show you the whole case. You can see the rexus which is much smaller than the opening, and this gives you a wide view. And in SICS also, it's very, very useful. Works very well in SICS. So the next one is some pupils are very large and some pupils we want to make it small, especially when there are corneal opacity. See, this opacity is not very obvious here, but then it is definitely an opacity there. So this pupil, if it remains normal size, there will be a lot of aberrations and glare and all those from the side. So if you make it smaller, this is the single pass 4th row pupilloplasty. So you use 9-0 or 10-0 Prolene. And this is a straight needle, 16 millimeters. It comes from, I use it from Oral Lab, no financial interest in that. And then take it out and bring the segment which is there here, and then make the loop and make 4 throws into the loop, and then tie it. One knot is enough, you don't have to make multiple knots. So the Purkinje image has to match, the 1 and 4 has to match within the pupillary area. That is what we need to make sure. You can make, this is, I am making 4 throws. Four pupilloplasties, so that the pupil becomes close to 1.52 millimeters, and this one will give you a very good aberration free. See, this is how you make sure that the Purkinje images are right in the center. And here, this is another case where we have already done where we have already done an iridodialysis repair. So when long-standing iridodialysis repair happens, there is loss of tissue. Come, please come. There are seats here. Come, please. They might have come for the next session also, maybe, but still we'll ask them to come inside. Anyway, so once you do the iridodialysis repair, sometimes you will have a large pupillary area defect and all those. Sometimes it will be very, very odd, because long-standing ones, there will be tissue contraction, fibrosis, and you will have less tissue there. But then we can do, after dialysis repair, we can do a pupilloplasty also. This is how we do. Again, see, hold with the forceps is very important, and then make one, take a bite on one edge, and then hold the other side, and then take, otherwise you can take a 26 or even 30 gauge needle through the other side and railroad this and track it out. Once this comes out, the segment which is here, this is pulled out through the paracentesis. Here we need a paracentesis. Here you don't need a paracentesis. And now 4 times you pass. Many ways are there to pass 4 times the free end through the loop which has come out. And 4 times, once it is 4, 5 is not required, too bulky, 3 will not stay. So 4 is the best. And 1 pull and the knot forms. And you can have intraocular forceps to cut the, don't cut it too close. You can leave a little tip free. And then there is these larger openings, please close. The topmost one we can leave, because it will act like a PI. And if it is under the iris, it is fine. So once this is done, the pupil becomes smaller and you get a much better quality of vision after this procedure. Thank you very much.
Thank you, Dr. Minu, for that, as usual, wonderful presentation. And thank you especially for that making the pupil small. That also is equally important in giving good results and getting. Thank you.
Now it's the turn of our chief instructor, Dr. Sony George. He doesn't need any introduction. He is the head of the Vasan groups in Kerala branch, and he'll be talking about the perfecting IOL selection for optimal patient satisfaction. Over to you, Dr. Sony.
Thank you, Dr. Rohit, for the introduction. And now, earlier we had a situation where you could offer the patient a couple of lenses, and Indian, foreign, foldable, etc., etc. But we never used to really worry about what is actually the span of vision, what the patient really needs. But the times have gone, and cataract surgery is becoming a refractive surgery. And now we see, even after the age of, this is data from 2010, even above 65, 53.1% use internet and 14.5% use smartphones. And the working distance on various gadgetry, we need intermediate vision is also as important. So, coming to the material, I don't think we should emphasize any more, because hydrophobic acrylic is the lens of choice, and with the Indian companies coming, it's become very affordable. So the consideration about selection of an IOL, one is the economics. After all the good work done by during the FACO and all the other steps, it should be helping the selection of the IOL, and it should help, the IOL should help improve the vision to the best extent. So economics is one criteria. Like I said, now Indian companies have come with good IOLs. Photic phenomena is very important. You have to look at the profile of the patient, what kind of work they do. Do they do a lot of driving, etc., etc. So astigmatism, nowadays, we always have to offer any patient with above 1 diopter of astigmatism, we should offer them a toric IOL. And functional working distance. Now this is new. Most of us do not read at the conventional 33 centimeters anymore. We usually, because we are used to gadgetry, mobiles, laptops, etc. Our new working distance around near vision is around, the newfound vision is around 40 to 45 centimeters. So that also decides in the lens selection. Like in economics, I said hydrophobic IOLs are plentifully available from the Indian companies, and aspheric IOLs too. And multifocals also. There are many Indian companies which make good multifocals, like the few like Icral Active from Biotech and Define from Oro Lab. This give excellent vision. But then we have to prime the patient about the photic phenomena, etc. For the people who do not want that, we have the Indian EDOFs like the Swiss Phobe from Apasami, the Vivid from Oro Lab, which give pretty much good results and minimal photic phenomena. Looking at the photic phenomena, if that is the main criteria, lenses like Vivity, the X-EDOFs are one very good lenses which give the photic phenomena profile almost like a monofocal. You have the Geometric Plus from Hoya, which also is a trifocal, but with almost 10% loss of light, the AT Lara, or the Panoptics and the AT Lisa, the trifocals are still good with a loss of around 12 to 14% of light. The more the number of rings, the more photic phenomena. The more loss of light, the more photic phenomena. Astigmatism, it is imperative that any multifocal or any EDOF lens, you should have a toric version because it is unforgiving. Residual toricity is unforgiving. So functional working distance, again, you have the geometric plus, etc., which give you a very good vision at around 40-45 centimeters, the Vivity too, and the Swiss Phobe and the Vivid give. What you can do in these cases also, the patient wants photic phenomena free, glare free vision. You can always do a micro monovision in the non-dominant eye, and that will help him to recede the reading distance around 30 to 35 centimeters also. The only thing is you need good light, good ambient light, because the light is being split up. So going through a few of the lenses, one of the multifocal still available good lens is the AT Lisa. You have the AT Lisa Tri family. So you have a near rad of 3.3 and 1.66. Wonderful lens. Showing the video just to show that there's a no touch this one. This is the cartridge which comes in solution. You don't need to touch the lens alone at all. You can just place it, remove the cap, and then inject the IOL. And this is how the lens looks. Obviously, the rexus should be good. The overlap should be perfect so that the ELP is maintained. And the Panoptics also, it's called the Enlightened technology, which are continuous range from 40 to 80. And this is how the lens is being injected. For want of time, so any toric multifocal, any multifocal or trifocal, you should go for the toric version. The Swiss Phobe is a low-cost Indian version. So this works by aspheric correction. So normally you do an aspheric correction around -0.2, -0.27. Here the central area is aspherically, preferentially corrected so that you get a better depth of vision. And the periphery gives good far vision, and this is what it looks like. It works very well in 67% of my patients. It works well with 6.6 N10. Like I said, of course, I do a micro monovision correction and visual disturbance. And compared to Eyhance and Magnificent, it is much better. The Vivid is another one. It has got a central refractive zone and the peripheral diffractive zone, which accounts for the improvement in vision. Again, with a micro monovision correction, I can almost offer almost 70% patients with 6.6 N6. And the well-known, one of my favorites is the Ksos Vivity, which has got two surfaces. The central area, the elevated platform around it is the one which stretches the light, and the central portion shifts the light, and this gives you a continuous range of vision. And this is how it looks like. And the halo profile is almost similar to a monofocal, just showing the lens being centered. And this is just to show that it can be implanted in a rexis runout also very comfortably, owing, especially with the tackiness of the lens. And this is how the lens looks like in the post-operative period. Vivnex, geometric and geometric. See, it's got a truncated area in the center, and this area is responsible for the intermediate and near adhesion. And here the light is split. The geometric has more of far vision, and plus has more of near vision. Like at a 3 millimeter pupil, 21.8 of near and 50.8 in the geometric, and 32.8 in geometric plus, and 39 point in this thing. So comparatively, it's got a very good defocus curve. The injector system is fantastic. It's a no-touch loading system. This is the lens, and this is how post-operatively it appears. So now presbyopia correction and premium vision, range of vision can be offered to more patients irrespective of the financial status, level of activity, and astigmatism. Thank you very much. Now moving on to the next speaker, let me proudly introduce Dr. Nivian M. From MN Eye Hospital. He's a second generation ophthalmologist. He and his second, right? Okay. And his brother, they've taken up the good work of Dr. Madhivanan and Shalini Madhivanan. And he's a prolific retina anterior segment surgeon. And why I chose him to come is mainly because he has invented something, the MT Flex. And this is a very good lens for scleral fixation. And I think it has not reached the adequate range of people. So over to you, Dr. Nivian, and thank you for coming over.
Thank you, sir. So respected teachers, senior ophthalmologists, my dear friends. So after we had a session on perfecting cataract surgery, so this is something that none as ophthalmologists want to have. So how many of you are in the audience here do secondary IOLs? Can you raise your hands? So that's good to know. And how many of you have had PCRs? Yeah, there are more hands raising up. So what I learned is, as cataract surgeons, all of us are going to have complications. So how we manage these complications and give good visual outcome is what differentiates a good and being a great surgeon. So let me just take you through all the various options in this short time. The first thing is the claw lens. The retropupillary claw lens is always an easy and a simple solution. So this was a case of aphakia. The principles of management of any aphakia is the same. I always stain the vitreous with tricot and then wash it, because only then you can see the vitreous very clearly. Otherwise, we keep cutting blindly. So in this, through the anterior approach, you can use the irrigation on one side through the side port and the cutter, either the 20 gauge cutter, because 20 gauge cutters are there with all phaco machines. It is just that you should know how it works and whether you are sterilely having it. The secret of vitrectomy is just stay in the center. See, in vitrectomy, you don't have to move the cutter. We have a false thing that we keep moving the cutter fast, it doesn't cut the vitreous. Just stay in one place and the vitreous will get cut. And as long as the central vitreous is cut, you can stop. You don't have to go inside and deep. You're not doing a complete vitrectomy. We're just making sure there is no vitreous prolapse. And make sure there is no vitreous in the wound or in the section. So the claw lens, one more important thing is the forceps that you use. It should be that broad tooth forceps, because you need a firm grip to have this enclavation. And also just check before going inside whether that gap is there, because sometimes there's a fusion there and then you go in and keep pressing, you can damage the iris. For all secondary IOLs, I think that 0-180 degree is very important. So where you are going to clip the lenses. The technique that I use here is my second instrument is already there and in the mid periphery of the iris where I want to clip. And then I take the IOL inside and then the right hand goes up, left hand comes down. Because that avoids you going down and keep searching for where you want to clip. And then just a mild thing, you will see the dimple. So now moving on to the other side, you see here again my hand is going to the mid periphery where I want to actually clip. Then I take the IOL inside and then slightly raise the left hand and the right hand pushes down. You'll see the small dimple. So as long as it is the mid periphery, you get this nice round pupils. If you come very anterior, you get these cat eye kind of pupils, and don't go too peripherally because you can damage the root and cause bleeding. One of the other options that we have is the flange technique. This is slight modifications of various technique. So here what we use is, we have a 90 Prolene needle. So again here the 180 degree marking is very important, and 1.5 away from the limbus, we're just threading the needle and railroading it and bringing it to the other side. So basically this thread now dissects the eye into two halves. So just go in and pull the suture out and then cut it. So now you have 4 ends. So any rigid IOL can be used for this technique, as a lot of us start with SICS and then move on to phaco. So just put the Prolene sutures through the holes in the IOL. I usually prefer to do one from up down and the other one from down up, just to avoid the tilt of the lens. And using a cautery, just make sure you make a small bulb. But only thing is, make sure the bulb is large enough that it doesn't slip through the holes, because the holes in different IOLs are slightly different. So then place the lens inside and then pull the two strands. Just make sure the centration is there, and then again flange the suture. So once that is done, so it's a relatively easy method of doing a type of secondary IOL. And you have good centration and good results with this. But again, these two are all, you have to have a scleral tunnel, extend the wound and do a secondary lens. So moving on to this thing, the CMT Flex IOL, a new option for aphakia. So the invention started way back in 2017 when the concept was, we have so many different techniques of secondary IOL, but they were all modifications of the 3-piece lens or a single-piece lens that we already have, like the glued IOL, the Exnic technique, Yamane technique. So that came that why not have a specific design of an IOL? So the CMT Flex is nothing but a single-piece hydrophilic lens with specialized T-shaped haptic. So basically when you pull this T-shaped haptic outside, it just sits there, and that prevents the lens from falling back. So for any secondary IOL, again I said that 180 degree marking is very important. So we make two 2 by 2.5 scleral flaps. Then again 1.5 millimeters away from the limbus, we make a 23 gauge sclerostomy. So we also have specially designed forceps that comes with the lens that have the slightly broad tooth, but not sharp. The advantage of this lens is it can be done through a clear corneal incision. So you can use the existing incision or you can make a fresh incision. As you can see, the T comes out first, just hold the lens. So the trick here is don't pull now because it's a single piece lens. So just inject the remaining of the lens from the cartridge and free the lens. So the trailing haptic sits on the iris or in the wound, and then start slowly pulling it. When you pull it near the sclerostomy, there'll be a slight tug, but then it just pops out and stands. So because of the design, it just sits there. So just a small animation. It can be done into any normal IOL cartridge and loading through a clear corneal incision. Grab it and then pull it out of the sclerostomy. It opens up, pops, and just sits there. For the other side, we use the handshake technique. Again, just exchanging it to the other hand and then bring it out. So once that is done, you don't have to do any other maneuvers. We just close the flap, and then the conjunctiva over the flap, you can either glue it or you can suture it or even cauterize it. Because here the glue is not holding it because of the thickness of the lenses. There won't be any leak or hypotony. So these are some of our 7-year results of the UBM pictures to just show the position of the lens compared to all the other secondary IOL lenses, and there is no pigment dispersion or secondary glaucomas in it. So now lots of people have started using it, and some of the few tips that I started giving is you can either use the MVR blade instead of the needle that we make for the 23 gauge sclerostomy. The second thing is we make the incision perpendicular to the limbus. So when you make it perpendicular to the limbus, the T actually sits at 90 degrees. So when you're pulling the other side, there are less chances of this slide slipping outside. As you can see here, before we used to make it parallel, if you make it perpendicular, the T sits like this. So the less chance of slippage of the IOL back inside. We also have an angulation. So there is a hole on the top right that shows there's a 10 degree angulation. So basically this angulation is so that it sits away from the iris and there is no disturbance as far as pupil dilatation is there or any pigment dispersions. So we have that hole on the top right. Some of them use the hole with a dialer to even exchange the lens. The third thing is that head-on position. See, when you hold it like this, what happens is when you're pulling out, the two T's bend inwards. So basically what I'm trying to say is there's a lesser diameter that comes out. So it is easier to pull out the lens than holding it anywhere else. Finally, a last case again, for anterior segment surgeons also it can be done. So this is basically the only difference is you will have to use an AC maintainer. As I said, for any secondary IOL, the hypotony is the biggest challenge. So you use, this is an AC trocar. I think Minu Mathun sir does a lot of cases using the 25 gauge AC maintainer. So basically we had to remove this lens and then plan for a CMT flex IOL. As I can show you can do it in any IOL cartridge. Just grasp it, then they inject the remaining of the lens and then pull it out. These are just small modifications that we are slightly doing now. We also have the curved forceps now because a lot of people said it is difficult to do the nasal side. So now we have curved CMT flex forceps. So it's easy to go inside and removing it is also easy. And then one of my colleagues said, why not use a trocar instead of making sclerostomies? So only thing is you'll have to pull the trocar out first and then release the lens there. So once that is done, just remove the AC trocar. As I said, for any secondary IOL, make sure there is no hypotony, and AC trocar is better because otherwise you start using a lot of viscoelastics. The more viscoelastics you put, that goes inside, and that is one of the reasons for secondary glaucoma and iritis for the patients. Complications, yes, we do have complications in any secondary IOL. There can be breakage if you use any sharp instruments. Too much of excessive force can break it. But then it has been a long journey from the inception. Now people from all across India have started using it. But there I would like to thank Minu Mathun sir. He was one of the first ones to actually believe in the lens, and as an anterior segment surgeon, he's given more talks in forums, and I've learned a lot from him as far as CMT flex IOL is concerned and some modifications. We do have a lot of publications including the Kerala Journal, and now next year we'll be launching it internationally after we get the European license. So once again, thank you Soni sir for having me here. It's been a pleasure to be in KSOS. Thank you for making it happen.
Thank you for that wonderful presentation, Nivian. Now I call upon Dr. Mohita Sharma. She again doesn't need any introduction. She'll be talking about laser capsulorhexis. She is the chairperson of Tirupati Eye Center, Noida, and also the president of the Women Ophthalmic Society. Over to you, Dr. Mohita.
Good morning, everybody. So after hearing a lot about cataract and what all can be done in various type of cataract surgeries, I'm introducing a new technology to you, which is called advanced laser-assisted capsulorhexis. Now, what is this advanced laser capsulorhexis? It is a customized optical laser delivery unit for a precise capsulotomy during cataract surgery. Now, we all have been doing capsulorhexis ourselves, whether using a needle or using a capsulorhexis forceps. But currently, with the coming of the presbyopia correcting lenses, there is a need that our capsulorhexis should be absolutely circular. Capsulorhexis should be of a desired size, and we should have consistent results. So this is the equipment setup. You can see that there is a console, and this is a console which is attached to our own regular microscopes. This is actually in the study stage, but will soon going to come into the commercial market. So that is why I'm introducing this technology to you, and I've been working on this for last 2 years with Appaswamy Associates. So this is attached to the microscope, and this is the laser module demonstrating the front panel. Where you can see various settings, and the good thing about this rhexis is we can actually customize the size of our rhexis that we want, and we can vary it from 4.5 to 7 millimeters. So as I said, what is the need? Reproducibility and consistent outcomes, and for our precise lens positioning and centration of our current presbyopia correcting lenses, we need accurate capsulorhexis. So we started by doing an animal study with 50 eyes, using all ethics that were applicable to animals, and these are the kind of results that we got in our animal eyes. And after this, we started with, and these are the retrieved anterior capsular flaps, which were analyzed in the electron microscope, and it was found that these flaps had outturned edges. So this was probably responsible for the rhexis having a very good strength when we actually did it on humans. This is the patent certificate, and this is how it gets attached. It just comes as an attachment which is attached to the microscope while we are doing the surgery. Now, what is so unique about this? The design, which is a customized laser for laser delivery, the efficacy, because it gives a higher capsular, it's a very high capsular edge tear strength, and the technology, because it gets seamlessly integrated into our regular microscopes. The advantage over other technologies is, for example, Femto and Zepto, etc., which have been available. One is that it does not require additional suction effect for globe centration. And secondly, we have done it on almost all types of cataracts, except for the fibrotic capsules. All other capsules, it has given good results. As I said, it has a high capsular edge strength. If we compare it, say, with Zepto, which had a kind of a zigzag kind of a rhexis, this is basically a coagulating laser. So that's why the rhexis is continuous. And since it's indigenously made in our own country, it's going to be much, much more economical than any other technology. So I'll just show you a short video of this. So as I had shown before, this is the attachment which gets attached along with the laser filter, which is switched on for protection. This is a regular phacoemulsification being performed. Staining is very, very important in this. The two different things that we do compared to any regular cataract surgery is, one is the stain that is used is of higher concentration, and secondly, the viscoelastic is also of a much higher concentration, because these have been optimized by trying various permutations and combinations to find out which is the medium through which laser will travel the best, and which is the concentration of the stain where the laser uptake will be optimal. So this is the rhexis being performed. As I said, staining is a very crucial step. So if we find the staining is not adequate, we may restain. And as you can see, these are the kind of flaps that are achieved. And again, we have sent them for scanning electron microscopy, and we have found that the rhexis margin is actually kind of interned, and the margins of the margins of the flap are outturned, and maybe that is the reason why, as you can see, we are pulling with two instruments and yet it does not break. And this is especially what I've chosen to show to you is a hard cataract today in this case, because even when we are we have tried in very hard cataracts also, even when we are maneuvering the pieces out, the rhexis does not rip apart. So it has a good strength. And as I said, we can choose how much of the size of the rhexis we want. If for small people, we can even go for 4.5 or 5 millimeters of rhexis, and followed by lens implantation. So this has been worked out after, as I said, with a lot of permutations and combinations on how much is the adequate power, how much is the stain concentration, how much is the visco concentration, to get finally what we want. And we are in the final stages, and this is one case where restaining was done. This is the crucial step. Staining has to be adequate, and contraindication is there is a corneal opacity, because then the laser does not penetrate very well. We have also done specular time counts to find out if there is any effect on the endothelium, and we found that it is like a regular phacoemulsification laser, does not damage the endothelium also. So this is about this new technology, which you will soon hear about, and this was an introduction to this technology. And before I end, elections AIOS are around the corner early next year, and since I am a contestant, it is my duty to inform you all that I am contesting for Joint Secretary, and I would need your support. I've been the Secretary of Women Ophthalmology Society as well as of UP State Ophthalmological Society for last 7 years, and if given an opportunity, I would like to serve in AIOS too. Thank you.
Thank you very much, Dr. Mohita. And let me thank all the speakers for their one fantastic presentation, and for the lovely audience for listening. We'll have a photograph outside while the next set of presenters are coming up. Thank you very much.